Okay, thank you, Andrew, for that introduction. What I'm going to be talking about is the use of psychedelics in treating addiction. So first, I'd like to disclose some advisory relationships in the area that I'm showing on the screen right now. So I'm going to be focusing mostly on research on psilocybin. That's the active agent in over 200 species of mushrooms. Psilocybin is a classic psychedelic, so that puts it in the same category as LSD, mescaline, dimethyltryptamine. So these act by serving as agonists at the serotonin 2A receptor. And so this is going to be a different mechanism than other drugs that are sometimes more broadly called psychedelics, but they really work through distinct pharmacological mechanisms. So this would be MDMA, ketamine, PCP, for example. So a lot of what I'm going to say about psilocybin is going to be largely applicable to these other classic psychedelics like DMT or dimethyltryptamine. So these classic psychedelics, as I mentioned, have serotonin 2A as their primary site of activity. And we know that through a variety of mechanisms. We know that these drugs produce discriminative stimulus effects. By that, what I mean is you can train a rat or another non-human to essentially tell you whether they have received a certain type of drug or another drug. You can train them up on, for example, to discriminate whether they've been given an injection of LSD or a saline injection, and then see how another drug such as psilocybin, how they'll respond to that. And it turns out that they will respond to these different classic psychedelics like psilocybin and LSD as if they were the same type of drug. So that tells you a lot about pharmacological class. And so these drugs reliably produce discriminative stimulus effects by those procedures. And we know that antagonizing the serotonin 2A receptor, in other words, blocking the effects of that receptor, will block the effects, both of these discriminative stimulus effects in animals, and also the subjective effects in humans that are receiving compounds like psilocybin. Another piece of evidence that the serotonin 2A is critical is that the affinity or the stickiness for the 2A receptor is extremely well correlated with the human potency across different drugs. In other words, how many milligrams of that substance do you need to achieve a certain level of effect? And those data are shown here, just a really tight correlation between the human dose along the x-axis and the affinity for the serotonin 2A receptor on the y-axis. And several of those compounds, those potency data, came from Sasha Shulgin. This is a photo of me and Sasha when I visited his lab in 2007, just a few years after I had started my research with psychedelics. And if you're not familiar with this character, if you're interested in psychedelics, you definitely need to check out his work. He passed away a few years ago, but he left these incredible volumes. His really largest and most important pieces of work are in PCAL and TCAL, these two books that describe his synthesis and experiences on hundreds of these different phenethylamine and tryptamine compounds. So psilocybin and some of the other classic psychedelics have an absolutely ancient history of use. In fact, that goes beyond before recorded history. So I'm showing you on the left and in the middle some artifacts from either Mesoamerica or South America dating back hundreds or a few thousand years. I'm showing on the right a cave painting from northern Africa. Dates back to estimated around 9,000 years ago. All of these likely depicting the sacramental use of psilocybin mushrooms. And so, going back to 9,000 years, that predates the earliest civilizations in Mesopotamia by a few thousand years. So this is absolutely ancient So fast forward some millennia, and we get to the 1940s, this earlier era of the psychedelic research heyday. 40s through the 70s. Psychedelics were intensely investigated as research tools in therapeutics, and there were promising findings for cancer-related distress and alcoholism. That was primarily research done with LSD. And then there were the dark ages. So despite promising early findings, there was this decades-long dormancy in human research with these compounds. And this was really a reaction to both the casualties of reckless use, and not really the use in well-controlled clinical research, but casualties to the street use of these compounds and to the sensationalisms that surrounded these compounds in general. And so right now we're back in the sort of after the Dark Ages, in the Enlightenment, where it's been called a renaissance of psychedelic research. So I'm showing you the PubMed hits, or the psychedelic citations per year for psychedelic, or a synonym hallucinogen, going back to 1980. And I'm just showing you a fairly steady baseline for a couple of decades going back to the 80s, and at a very low level, just 10 or so papers a year. And then in the early 2000s, around the time that I got started in this research, there was the beginning of an upswing of interest. And so now you see this exponential growth with what has to be now hundreds of papers being published per year going forward. These are powerful tools, these classic psychedelics, and like many powerful tools, I think they can have beneficial and dangerous effects, very much dependent on how they're used. And if you're using them towards benefit, and whether you have used mitigating strategies to minimize and address the potential risks. So I've written some papers going back to early in my career, and it's been a continuing theme for me. I had a 2008 paper recommending guidelines for doing this type of clinical intervention safely. Just a couple of years ago, I published an abuse liability assessment covering the risks of psilocybin, and how the FDA should likely, based on the data, regulate these drugs if they're approved as medicines. I won't go through all of these, but the real biggies are that it appears that certain individuals, a small percentage of the population who might be prone to a psychotic disorder like schizophrenia, or have an identifiable predisposition to those disorders, that they could be harmed long-term by the use of these compounds. And then really for anybody at a high enough dose, regardless of their psychological health, people can have a bad trip, what we call in clinical research a challenging experience. Because oftentimes it can be a very a meaningful experience for people, and one that's highly valued after the fact. But nonetheless, if the person is not in a safe environment, it can in fact be bad, in the sense that someone could engage in dangerous behavior when they're panicking. And although it is rare, admittedly, even with recreational use, sometimes people are hurt when having a panic reaction in a bad trip type situations. So the most important thing here is to say that every single one of these known risks, we have very good methods through both preparation and monitoring, follow-up care, to squarely mitigate these risks. One risk that I'm listing at the bottom that's very relevant in using these compounds to treat addiction is that they appear to lack a potential for addiction themselves. So that's weird for a psychoactive drug that can certainly be abused. And to be clear, these drugs can be abused, meaning just that they can be used in an unwise way that can cause harm to either the self or other people. But they're not drugs of compulsive drug seeking or addiction. No one is jonesing for their next, psilocybin or DMT or LSD fix. So that's, again, important, especially in exploring them as addiction treatment medications. So, okay, Yeah, no one is going to be jonesing for their next psilocybin fix, but why would we expect it to potentially help people with addiction? Where there's a few lines of evidence that can be brought to bear. One is just looking at this anthropological literature that's been written over the last several decades, documenting cases of the sacramental use of these classic psychedelics, whether it be mescaline and peyote or be it uh, DMT and ayahuasca, that their sacramental use by indigenous cultures or syncretic religions have been associated with a large number of stories of addiction recovery across a number of substances of addiction. Now, of course, those aren't, that's not clinical research. We do know that religious involvement in general, it can be associated with addiction recovery. So by itself, certainly not conclusive, but highly suggestive, considering that so many of these cases, the people are very clear that it was experiences with these compounds that pulled them from the jaws of addiction. But another line of evidence goes back to the work that was done with LSD in the 1960s and 1970s to treat primarily alcoholism. And it was originally reported that was sort of in several reviews that literature was a mixed bag. Some trials found significant effects, others didn't. And several years back in 2012, a meta-analysis was published of just the six there, and there were only six randomized studies using LSD to treat alcoholism. And so randomizing to either LSD or some other control condition, and it varied across studies. But a meta-analysis is essentially a way to take different studies that use somewhat different methods and reported different results to get them to speak the same statistical language to see if in aggregate there's a signal that's stronger than you can detect in any one study by itself. And what I'm showing you on the x-axis of this figure here from that paper is the odds ratio of improvement. So anything on the right of that center line, centered at 1, at the number 1, anything to the right is showing odds that are favoring people to have greater improvement with LSD, and anything to the left would show a greater benefit for the control condition in that study. So you can see that in terms of trends, every single one of the studies was to the right. So whether they're statistically significant in the original study, even if they had a small sample, all of the trends were in the right direction. Even in one study where they literally strapped people down to bed with minimal preparation about what was going to happen to them. Overall, as shown by the large diamond, that's the aggregate across the 6 individual studies. There was a very significant effect statistically, and more important than statistical significance is the effect size. There, essentially, it was an odds ratio of about 2, meaning essentially LSD nearly doubled the odds that these patients would be improved at the first follow-up. So, and that still rivals certainly anything we have today in the treatment of alcoholism. So that combined with a little bit of research also on LSD and the treatment of heroin addiction that looked promising, I decided over a decade ago, that's when I got started on this, to look at cigarette smoking. It's something I had a lot of research experience with going back to my graduate school days. It's a great model system of addiction. It's very quantifiable, very easy to biologically verify, even with multiple methods through getting breath and urine samples. And in some sense, it was an interesting case to see if there was this cross-signal anti-addiction efficacy, which is the really intriguing thing, because most of addiction medicine is treating, one particular drug class or another, the addiction to those drug classes. And so, by quelling the response or the craving, the withdrawal mediated by that receptor system, responsible for those drug effects. But this is sort of different. Why would you get this signal across these different drugs, and you add in the anecdotes across, you name it, the drug of addiction? There are anecdotes of people recovering with these classic psychedelics. So, what's going on there? That's the interesting thing. So I decided to test the boundaries of that with cigarette smoking. And aside being a great model system of addiction, it's kind of an issue in and of itself. I'm showing you here deaths per year in the United States alone, on the figure, which is nearly 500,000 uh, due to smoking. And that absolutely dwarfs all of the other drugs, alcohol and the other drugs combined. I mean, all of the illicit drug deaths per year hardly is even visible put on the same, screen as showing the number of deaths from tobacco. Um, and that extrapolates to about it's estimated about 5 million deaths worldwide, due to smoking. And a whole lot of people want to quit. It's not like it's just something, everyone enjoys and no one is concerned about. In the United States, over 2/3 of smokers want to quit. And so I'm all about certainly developing tools to empower people to live better lives and to achieve their own goal. And then, even the best medications that exist for smoking cessation fail to help the large majority of people remain smoke-free for the long term. So this work has gotten a lot of publicity, which I always appreciate, but you don't always control the headlines or the photos used by the media. And so hopefully you've gotten the point by now that I'm not, there are risks. I'm definitely not encouraging people to take mushrooms on their own to quit their smoking. However, I want to put double emphasis on this point. Whatever you do, definitely don't take that many mushrooms, because that's crazy. That's a lot of mushrooms. So they didn't clear that by me. So I'll just leave you with that. The demographics for this pilot study that we ran on psilocybin for cigarette smoking cessation, really the important take-homes are that these were not lightweights. They had been smoking on average for about 30 years, and they had been, and they smoked about a pack a day. So these were the real deal smokers, all had multiple previous quit attempts. It was a 15-week protocol involving weekly meetings over that 15-week period. And as the backdrop, we use cognitive behavioral therapy. That's the standard sort of talk therapy that is usually used to help people quit smoking. And to be clear, this was not done during the psychedelic experience. That was like in our other studies and really most of the other studies in the field at all institutions these days. The session itself was largely introspective with psilocybin. So the person wearing eye shades, headphones through which music was played, where they're told to go inside, trust, let go, be open. And they're not given any specific instruction about analyze your smoking. Whatever comes up, and you need to kind of use this radical courage to face whatever happens in your experience. So the cognitive behavioral therapy was done in the preparation sessions before the psilocybin, and then in follow-up sessions after the psilocybin. So there were 3 psilocybin sessions in this first study, ranging from a moderate to a high dose. And the first psilocybin session was on their target quit date that was assigned several weeks ahead of time. In other words, the date at which we had planned, like that's the day you're going to quit smoking. You're going to have your last cigarette before that. So jumping to the results, this is a graph showing breath carbon monoxide. That's a byproduct from smoking, very reliable in terms of detecting whether someone's recently been smoking. Here are the median data before the first psilocybin session, and here are the data after the first psilocybin session. You don't need to be a stats whiz to see you have a pre-post difference in these data. And here I'm showing you the abstinence rates across participants at various time points. At 6 months, this was an 80%. 80% of the people were biologically verified as abstinent, which is extremely high, more than twice the rate that you see even with the best medications out there. And then that held up on at an average of 2.5 years. That held up to 60% of people biologically verified as smoke-free, which is just a staggering result. So I'll tell you a little bit about this mystical experience that we've looked at repeatedly in studies, and others have as well. It sounds a little woo-woo, I admit, but it's actually a valid psychological construct that's been empirically validated. It has deep roots going back to William James, the founder of American psychology, who was fascinated by this idea that extraordinary experiences described by humans across the centuries, across different parts of the globe, from people speaking different languages, from cultures that had different religions. Despite all that variation, these extraordinary experiences often had incredible similarity, and that, you know, he just felt that it has to be the same phenomenon unfolding across these individuals. And so these mystical experiences involve a number of psychological aspects: having an overwhelming sense of unity, such as all is one, or I'm part of everything, one with humanity, an overall positive mood to the experience, a sense of transcending time and space, and ineffability. In other words, no matter how hard you try, you could never fully put the experience into words. And I'll just say briefly, even though these quintessentially these experiences are said to be ineffable, you know, of course, as scientists, we got to do our best to get data whenever we can. So in fact, we really F things up by trying to get people to talk about the ineffable. Okay. So we've applied this scale, the MEQ30, that we actually developed in survey and in laboratory research with psilocybin sessions, to apply to a large number of studies with psilocybin. And in this study, we found that our assessment of mystical experience, the day they received psilocybin, so after the drug wore off, and before they went home, they filled out the questionnaire, that had a significant relationship with being more likely to be a non-smoker at the 6-month follow-up, and having reduced a significant correlation with reduced craving for cigarettes. And so that's in line with a number of our healthy normal studies that suggest that a mystical experience is driving an increase in personality openness. And in our research using psilocybin to help treat cancer patients with depression and anxiety, the mystical experience from sessions was significantly correlated with greater reductions in depression and at the 6-month follow-up. So those data were very promising, but they were it was not a randomized study. We could not really determine whether the psilocybin definitely caused the high success rates. The really only question was, is this worthy of follow-up? And the answer to that was absolutely, because the absolute rates were so high. But fortunately, where we were able to acquire the funding, thanks to the Hefter Research Institute and others, the funding for a larger randomized follow-up. So this is a trial of 80 people, 80 smokers randomized, 40 of them randomized to get the psilocybin treatment, and 40 randomized to receive nicotine patch treatment using the FDA label standard instructions, the standard way to use nicotine patch. And we scaled it back to only one psilocybin session for the psilocybin group, mainly for experimental reasons, because we're doing brain imaging, fMRI before and after, and it would add noise to the study to have multiple sessions. But so far, the data are really remarkable in terms of holding up. The study's ongoing, even though we're mostly done. It's not done, so the results could change. But for the 44 people who have gotten to their 12-month follow-up, we see that 59% of people are abstinent in the psilocybin group, compared to only 27% in the nicotine patch group. And to be clear, that's a very good result for a nicotine patch, which I'm proud of, but nonetheless nowhere near the success rates that we're getting with psilocybin. So it's still looking extremely promising. We're also seeing an early signal of one of the potential mechanisms by which psilocybin might be helping people. These are early results in a subset of participants participating in the fMRI before and after imaging. This is done by our colleagues at a lab at the National Institute on Drug Abuse Intramural Research Program with our colleagues Elliot Stein and John Fedota. We had people, and the imaging wasn't done during their psilocybin session, but before and also the day after their psilocybin session, or the day after they quit if they were in the nicotine patch group. But one of the measures we looked at was the multi-source interference task. It's sometimes called the oddball task. It's a measure of cognitive control. And essentially the way this works is that you're shown 3 digits, as I'm showing you in the 2 examples on the right, a 1 and then 2 zeros, or in the other case, 2 2s and a 1. And your job is to pick the oddball digit, which is the one where there's only 1 digit of that type. So there's 1 1 and 2 zeros, so you have to select the 1. Now, sometimes that's easy. Well, you also have to not just identify the digit, but the goal is to use the finger number that corresponds to that number. And so this is the tough part. Sometimes this is easy in the sense that the finger number corresponds to the spatial location of that number, as in the example on the left. Those are congruent type tests where there's not this interference. But on interference trials, the target number is in a different location than the finger that you have to use. So if the digit 1 is the oddball, you have to respond with the first finger, the index finger, which is in a different physical location as the digit on the screen. And so this is just like really hard for people. It kind of trips people up. And so reaction time is slower in these trials. And so by getting a difference between the reaction time in these types of trials, you can measure this interference effect. How well are people at dealing with and overriding conflicting information that they're supposed to ignore? And really interesting, we saw that comparing them before they quit with psilocybin or nicotine patch versus after they quit, we found that the psilocybin group had substantially and significantly reduced interference effect on this task, and saw no significant difference in the control participants who had quit with nicotine patch. And so that's interesting, and it was clearly in the data driven by a reduced reaction time in those interference trials. So they were dealing with that information, that conflicting information, in a more efficient way. So I might be extrapolating a bit here, but if it holds up, it might be pointing to this sort of mindful response people often report in the days following the psilocybin session. I remember one participant saying that after his psilocybin session, it was like he could deal with the cravings and they were coming in slow motion. He said he was like the character Neo in the movie The Matrix, where he was in that slow motion world where now the bullets are coming at him from the guns that they're just going in slow motion. So he sees one coming, he just like steps out of the way and it like flies by. Similarly, a craving is coming. Oh, okay, I'm starting to get a cigarette craving. Whatever, no surprise. I quit smoking a week ago. It's going to be gone in a few minutes. Just wait it out, step to the side. It's going to go by. This is really, way of this meta awareness around this, interfering, temptation. So perhaps that's what this task is pointing us towards. So it's not just with cigarette smoking. With modern data, we see early data from our colleague Michael Bogenschut showing reduced heavy drinking and drinking days in individuals with alcohol use disorder. In this pilot, a study of 10 people, he has now moved on to a large randomized study, so a very similar trajectory. And I've published in my group several naturalistic studies really trying to catalog the landscape of people claiming that, oh yeah, they say, oh, I've quit smoking because of a psychedelic experience. I quit drinking. I quit cocaine. I quit methamphetamine. I quit cannabis because of a psychedelic experience. So we've published data on all of that across these studies. And so there's a lot of interesting, it can't show causation, but it's definitely some data that is calling for some clinical research follow-up. And one of the big take-homes that has come from that is just, I'll show you one of the take-homes is that for smoking cessation, people who quit smoking because of a psychedelic, we asked them, how did your withdrawal symptoms differ from other times when you quit smoking, if you had quit smoking in the past? And one of the real pop-out effects is that in terms of the somatic, sort of the body symptoms, folks said the median the modal response was, the most typical response was, it was about the same, not a lot different, about the same. But when we get into the more affective or emotional withdrawal symptoms, anxiety, restlessness, depression, irritability, craving, that's where the modal response wasn't just that it was less severe, but much less severe. I think really pointing us in terms of a mechanism of enhanced emotional control. And I think it's showing us some commonality with the work we're seeing with reductions in depressive symptoms in depressed patients. So what's going on here? Why would it work for all these different things? Depression and cancer and outside of cancer, and for these different forms of addiction. I really think they're all pointing to common mechanisms, a narrowed mental and behavioral repertoire across all of these disorders, and certainly across all of addiction. I think of these all as addiction broadly defined, all different ways of being stuck into a mental and behavioral rut. And I think that this is likely something we're studying now in the smoking study long term. Is this supported by overly rigid brain network patterns? And is there a normalization of these patterns with the psychedelic session? And finally, I think it points to something really mysterious and important about the role of the serotonin 2A receptor itself, regardless of any psychedelic drug effects. It's still kind of a mystery exactly what these receptors, what their primary role is in humans and other animals that have these receptors. And so it may be pointing to, this sort of role in modulating meaning and sort of this molar mental and behavioral plasticity. And so kind of summing up my thoughts on how this affects behavior change, Michael Pollan credited me with the not very scientific sounding term of a dope slap effect. Basically, people are dope slapped out of their story. It's a sufficiently dramatic experience, and the psychedelics do this by opening a window of mental flexibility in which people can let go of the mental models that they use to organize reality. And I think that's about, ways that they have held themselves, that they have not allowed themselves to get out of this sort of trap, this narrow view of thinking. So a whole lot to figure out there mechanistically on how this unfolds, but that's where my gut points me. And so I've shown you a lot of work here, a whole lot of folks to acknowledge. I'm showing you on the screen here, and funding by a number of philanthropic organizations that have supported this work. My information is on here. But I thank you very much for your attention to this.